I am Pat Wilson. I am a clinic manager at Health West. I've been a clinic manager there for 8.5 years. I have a confession to make. I am not an expert in cryoneurolysis. In fact, we've had just a few come through our clinic, and I don't think I've seen any of them. The feedback from the therapists regarding this procedure reveal that they do quite well. They progress quickly. I'm not sure if this is due to pain or not, but not significantly better than a lot of our patients. What I am is a father of 7. And in my spare time, I coach high school wrestling. So what I'm going to talk about is cryoneurolysis as it pertains to the role of the physical therapist in clinic, pertaining to knee pain. So cryoneurolysis, our first part of this word, cryo, is cold, right? Neuro, referring to the nerve, and lysis, referring to destruction. So our working objectives of this presentation are just to get a working knowledge of cryoneurolysis and develop a new favorite 6-syllable word, establish the role of therapy following iovera treatment, postoperative considerations, understanding and employing joint fluid dynamics, identify abnormal biomechanics, identify muscle imbalances, and progress functional movement, because that's the bread and butter of what we do as therapists. Would anybody like to read Wallerian degeneration? I think Dr. Gustin covered that well. That's the scientific definition. This is the clinic definition. We're freezing nerves, right? -20 to -60. It is a demyelinating injury and internal structure without getting rid of the external structures. We get normal axon regeneration and remyelination. Sore knee, huh? Have you tried icing it? So our vehicle for delivering cold therapy or a treatment is liquid nitrous oxide. We've been using it for decades. Our 2 studies that Dr. Gustin went over deal with the infrapatellar branch of the saphenous nerve and the anterior femoral cutaneous nerve. So 2 studies that we're going to look at, and we see in this one by Radnovich a large sample, 180 patients. Great job. Decreased pain up to 150 days. They had significant pain relief, as outlined in the visual analog scale, and WOMAC scale, which is basically a measure of pain and how it affects our daily routine. So it is predictable and repeatable. So the WOMAC scale is a self-rating system which has people rate their current pain with daily activities, pain quantity over the last 48 hours, stiffness in the morning and evening, and degree of difficulty with daily activities. 17 different daily activities you rate yourself. So nobody looks at you doing these. Nobody grades you on your biomechanics or your movement quality, except us. This group, and I thought this was really statistically significant, doing a iovera treatment 5 days prior to total knee replacement. Look at the hospitalization. 2 days or more, their control group, 67% of these patients were in the hospital for 2 days or more, as opposed to 6% 100% of the iovera treated patients. I thought that was amazing. 45% fewer opioids during the first 12 weeks. When do my patients with total knees feel good? They feel good in the daytime when they are moving around. Fluids are moving. They have pain at night up to 12 weeks or even beyond sometimes. So we've got our iovera treatment. We are ready to dance, right? This is my son on the left, Ben. He's now 19. And my son on the right, that's Nick. He's 21. He's engaged to be married. Now, so we've had this treatment. Does our limp go away? Do our biomechanics suddenly get better? Does our obesity get better? Do our blood markers get better? These are all things I want to consider when I see that first patient following this treatment. We want to look at PT considerations. If they come into your office, how long has that pain been there? And what's that going to tell you? How long they've been limping? How long they've been not moving that knee? Comorbidities. Do they have hip and back pain? Do these patients walk differently when they come to your office? Mine do. Medications. Are they on pain meds? Are they on anti-inflammatories? Are they active? Are they obese and sedentary? I want to know these things. Length of pain and diffusion. That tells me how deconditioned they are. Also gives me an idea of decreased joint nutrition, synovial fluid movement, right? This is right out of the iovera brochure. Post-procedure, you're going to get swelling, bruising, altered sensation, pain, and tenderness. Tells me quite a bit, right? It's like a knee scope patient. Also out of the brochure. Utilize ice, no strenuous activities for 2 to 3 days, no NSAIDs for 48 hours, gradual progression to activity, and most side effects gone in 30 days. Yeah.
That's 90 to 120 days, the doctor said.
Yeah.
You gotta wait a month to get relief, and then you only have it for...
That's the side effects.
Oh, side effects.
Yeah. The bruising, the swelling. So what's our role? They send them, hey, gait, knee pain. That's all you got. It's written on your script. They're there Monday morning. So what's our role? We want to get them moving, right? We want to get that fluid moving in the joint. Fluid dynamic strategies. This was an interesting study I ran across, and you can see it's from 1979, so we've had this information for long periods, but this was done on dogs. Weeks of disuse, they put casts on dogs. This is not months or years. This is weeks. They showed cartilage thickness decreased 50%. Proteoglycans, those are the little cells that attract water, keep everything plump. They decrease by 50% as well. So basically, our basic information from this is if you don't use it, you lose it, right? Isn't that what we say as therapists, right? Get it moving. My job's easy. Synovial fluid at rest moves into the cartilage. It is imbibed into the cartilage. When we got activity, weight bearing, it moves out into the joint space. Its role is to lubricate, and as a nutrient transfer, it pumps nutrients into those tissues that need it, right? There's my friend Greg. He's doing a heel slide. So he's doing a couple things right. Maybe early on, that's what we give him after his iovera treatment. We got movement, we got range of motion. What are we missing? Therapists. Weight bearing. right? We want to get some form of weight bearing for some ideal nutrient transfer. We want to go full range and get rid of that stiffness. And we want to do it progressively. I don't want to give them squats. I don't want to give them deadlifts out of the chute. Comorbidities. What happens if I have patients coming in with back and hip pain as a comorbidity after iovera procedure to their knee? Do these people substitute? Yep. Chronic muscle imbalances created by that substitution pattern? Yep. So identifying abnormal biomechanics. And therapists, anybody that has a hobby of analyzing gait in the malls, in public places? Nobody? Where's Blake Jessen? Did he leave? Oh, heck. So let's orient ourselves to planes of motion, and we'll do a little bit of fun diagnostics of biomechanics, just some gait stuff, quick and easy. So our first slide here is sagittal plane on the left. So everything that you're going to see from the side view. So flexion extension, flexion extension. The middle view is our frontal plane. Anything that you're going to see from the front or the back, that's our frontal plane. And the horizontal plane on the right, that's our rotation. Anything you're going to see from the top down.
Just going to film you walk, if that's okay, just for educational purposes. No, it's good. Yeah.
Anybody see a problem with that gait? A little bit of hitch. Where's the problem at? Where at? Left side? Left hip? Is it a range of motion problem? No. Is it a strength problem? Could be. Is it a habit problem? Could be. Could be a pain problem. Where should her cane be for a quick fix? Put it on the right. Her pelvis is dropping on the right when she weight bears on the left. What plane is this guy substituting in? Frontal, right? See all his compensation patterns there? What's he doing? He's lurching over that side on the right, right? He's compensating for either I've got pain in that joint during that pattern, or I've got some weakness that I have to vault myself over my hip to stay balanced. So we don't know. So both of those were frontal plane problems. What's the problem with a frontal plane substitution? We got an abnormal shear at the joint that's going sideways. We don't have a pump that's sagittal plane, right? We've got this going on. We've got areas of the joint that are having abnormal wear because of that. And we know from our studies on clinical biomechanics, we get less sagittal plane excursion. They don't have a little bounce in their step. And one thing that I ran into multiple times just researching this was increased co-contraction. What's that mean? What's that look like? They're stiff, right? There's no bounce in their step. What's the worst thing about that is they're weight bearing on one little area. They're not getting that pump effect for that synovial fluid, right? So, good studies done. One last video. Where is he substituting? You've seen this. Be quiet. Flex forward. That's our sagittal plane. Oh, now we get to see him squat, right? Yeah. Other studies, I didn't include a lot of details on this one, but definitely reduce muscle function. We got muscle imbalances. If we got movement imbalances, they don't use those muscles correctly. So how do we identify muscle imbalances in the clinic? Biomechanics, we can kind of guess. Therapists, we're going to be doing muscle testing to kind of verify. There's our gluteus medius. That's a good way to challenge that. But what we really want, we've identified muscle imbalances, movement imbalances. We want to progress functional movement, right? We want it to look good and feel good. Sit to stand, gait, stair climbing, those are all functional activities. We can kind of equate a lot of these to knee function. 80% of my patients, if I ask them to squat without giving them instruction, the one on the left, that's what they do, right? Heels are off the floor. There's no glute involvement. Their knees are past their toes. That means we got a lot of patellofemoral compression. So I ask them to bend at the hip, and then I get the second picture. They all hunched over one, still no glute activity. I want what's going on at the far right. I want to wind those hamstrings up so they're involved in the process, the glutes and the quads. And I want to keep them balanced so it's functional. They can lift things. Nobody's going to lift a garbage can with the first two. And it equates to functional activities such as getting in and out of a chair. Stairs. First of all, can they do it, right? Can they get up? Can they walk a leg over leg? Those are things I want to know clinically. And then I want to progress them. How do I do that? I give them less assistive device. Maybe try a cane. Maybe without assistive device. In our clinic, we'll give them short steps to try. We got 2, 4, 6, and 8. We'll get them started with that. And then I want to know, hey, can you do step-ups without use of your hands or a handrail? How many people got to tackle curbs in their daily routine? Right? There's ramps everywhere. No? Not everywhere. Yeah? I look outside my window and I'll see somebody walking up a curb and they stop right in front of it. And then they go. So we talked a little bit about a lot of things. Working knowledge of cryoneurolysis and our favorite 6-syllable word, right? Role of therapy following iovera with a small I treatment. Postoperative considerations, not many, just a regular kind of compared to a scope patient. Understanding and employing joint fluid dynamics. Identifying abnormal biomechanics and muscle imbalances, and then progressing the little things that we do to progress functional movements. Those are all things that we want to consider with these patients. Yeah. So first goals for your knee patient, your iovera patient. Daily living, right? Stairs. Yeah, whitewater rafting. ADLs. Can they function throughout their day? My next goals are, can I get them back to work? Can I set them at ease? Can they actually make a living? Right? Can they pay for the house that they're trying to climb the stairs in? And if you want to make a huge difference, get them back to things they like, things that excite them. Those are the big things that you're going to make a difference in with these patients. You got 6 months with diminished pain in that knee. What are you going to do with them? Get them back to things they love doing, and you're gonna make a big difference in obesity rates, sedentary lifestyle changes. So, thanks for your attention.